Thank you for joining today's call hosted by the Jewish Democratic Council of America, or JDCA. My name is Haley Soifer, and I'm the Executive Director of JDCA. In the 2+ years since its founding in August of 2017, after the horrific sight of marchers in Charlottesville chanting "Jews will not replace us," and hearing Donald Trump declare there were very fine people on both sides, JDCA has established itself as the voice of Jewish Democrats, advocating for Jewish and democratic values, such as increasing access to affordable health care, expanding voting rights, ensuring gun safety measures, and combating the rise of hatred and bigotry in all its forms. Last year, JDCA issued an ad calling Donald Trump the biggest threat to American Jews, given the unprecedented rise of anti-Semitism and emboldening of white nationalism since he was elected. In recent weeks, we have seen that Donald Trump is clearly not only a threat to our community, but his failed leadership is a threat to all Americans. When asked last month about the unquestionable mistakes made by this White House in the early weeks of the COVID-19 pandemic, President Trump summarized his approach. He said, "I don't take responsibility at all." Several weeks ago, JDCA launched the Democrats Leading in Crisis call series to highlight Democratic leadership and expertise amid this crisis, looking at every aspect of the pandemic and how it's impacted our lives. We have brought together members of Congress and experts to better understand how we got here and how we emerge from this crisis. We've looked at how COVID-19 has impacted public health, the economy, elections, education, national security, the workforce, and we're thrilled that hundreds of you have joined our calls. JDCA is here for you as a source of information and expertise at a time when it matters the most, and we're thrilled to convene these opportunities to hear from experts and learn together. Today, we will look at the impact of the pandemic, including preparations that should have been made as we saw this coming, with the expert who co-authored the Playbook in the Obama administration, which unfortunately the Trump administration overlooked at a time when it needed it the most. I will now turn it over to JDCA board member Dan Berger to introduce today's speaker and to remind you to all send your questions to info@jewishdem's.org. Over to you, Dan.
Thanks, Haley. We are extremely grateful to have Jeremy Konyndyk with us for today's call. Jeremy is a widely recognized disaster response expert who, after many years as Director of Global Policy at Mercy Corp, served in the Obama administration for 4 years as the Director of USAID, Office of U.S. Foreign Disaster Assistance, where he oversaw the U.S. government's response to an average of 70 disasters in 50 countries every year, including the response to the Ebola outbreak in West Africa in 2014. In this role, Jeremy helped to write the Pandemic Preparedness Playbook, which clearly the Trump administration either was unaware of, misplaced, or intentionally disregarded. Since leaving the administration, Jeremy has served as Senior Policy Fellow at the Center for Global Development and as a member of the World Health Organization's High-Level Independent Oversight and Advisory Committee, which oversees the agency's Health Emergencies Program. We are incredibly lucky to have Jeremy join us and share his expertise and insight on global disaster response, and look forward to hearing his take on the stages of this crisis. First, what happened with the coronavirus before it hit our shores, and what could we have done to prepare for it at this early stage? Second, what went wrong once the virus arrived in the US? What we should have done to contain it or limit it in the early stages, and how we failed to contain its spread. What happened to testing, contact tracing, and other best practices? Third, what are we getting right and wrong at the current point we're in? Let's call it stage 3 of mitigation using social distancing practices. And finally, how do we move to the next stage and reopen the country while mitigating risk and saving lives? What is the end game, and how can we reopen the country given the risk, and what measures must be in place before we do so? So those are some initial questions, and we know you all have questions too. Please send them to info@jewishdems.org, and we will take as many as we can. Thank you for joining us, Jeremy. Over to you.
Right. Thanks so much. It's my pleasure to join you here today. And I've been working with Haley on various things since we were both much earlier in our careers, and she was working for Senator Coons and I was working for Mercy Corps, and we were both focused on how to keep people from starving in Somalia. So it's always, it's nice to see the same people turning up over and over, and trying to be on the right side of things. So what I'm going to do is I'll talk through a few minutes on how we got here, where we are now, and where we're hopefully going, and some of the things that will affect whether we're able to get this outbreak under control in the United States and the world. How we got here in the United States is, I think, a story of ignored signals, not so much a lack of signals, but signals that were there and were not taken seriously by the administration, and a choice not to prepare. And that is where I think the playbook that I helped contribute to, and I would say Beth Cameron, who was at the White House at the time, was sort of the lead architect of that. So I can't claim credit. She gets the credit as the architect, but I was a contributor and reviewer to it. What the playbook made very clear was that the U.S. government needed to be ready for disease threats that were going to be a lot scarier than Ebola. When I was served in the administration, I worked with Beth and with many others on fighting the Ebola outbreak in West Africa, and I think all of us who worked on that came away constructively terrified, I might say, by how difficult it was to get that disease under control, and how much more vulnerable the world would be to something that was more transmissible. So, Ebola is a difficult disease to get. You have to come into direct contact with the bodily fluids of an infected person, which, in the normal course of your life is not an easy thing to do. Something like COVID or, a novel influenza, which we were also very worried about, is much easier because it's a respiratory disease. So you can get it through surface contact. You can get it through inhalation if you're in sustained proximity to another person. So we were very nervous that a disease very much like this one would come at some point, and that the world and the United States needed to be more ready for that. So what we laid out in the playbook was a series of steps that the U.S. government should take when it began to identify or became aware of a disease or a pathogen with the potential to do that. And in the playbook, coronaviruses were specifically identified as a tier 1 pathogen in the same category as novel influenzas. And they were identified because we'd seen what SARS could do and we'd seen what MERS could do. These were two other coronaviruses, fortunately, both of which were less transmissible than what we're seeing with COVID, but they were also much deadlier. And so, we knew from that coronaviruses were concerning. They were identified as a tier 1 pathogen, and in general, novel respiratory viruses were seen as a huge threat. That's always been the huge threat. The expectation was often that we would see that through an influenza rather than a coronavirus, but coronavirus was known to be a real concern as well. So the playbook then went through and laid out a bunch of steps that should be taken when something like that emerged. And I won't go through all those now. I'm happy to get into some of those in the Q&A, or if you want to dig through my Twitter feed from a week or two ago, I go through some of the steps that were in the playbook that were missed. But the bottom line is, there was a tool there that identified most of the concerns that we're seeing now. It identified personal protective equipment and supply chain issues as an issue. It identified diagnostic testing as an issue that required early action. It identified the potential strain on the health system, engaging the sufficiency of the U.S. healthcare system to keep up with the potential number of cases. Identified most of the issues that we have seen become real problems over the last month. But it was not. It was ignored, and and what's equally interesting is that even if you say, okay, that was an Obama product, the Trump at White House wasn't going to touch it, they also had experts who saw what was going on and who also were ignored. And so there was reporting in, excuse me, there was reporting in the Washington Post last weekend and the New York Times this past weekend that talked about all of the warning signs within the administration and all of the individuals within the administration who saw what was coming, tried to elevate concern up the chain, and basically ran into a brick wall. And interestingly, the Trump administration had done an update to the National Pandemic Influenza Preparedness Plan in, I think, 2017, which also identified a lot of these issues and also seems to have been ignored. So, the way we got to this point was by losing the month of February. We had all the information that we needed at the end of January to make to recognize that this disease was a danger to the United States. By the end of January, the World Health Organization had announced a basic picture of this virus that remains pretty accurate till now. It identified it as having human-to-human transmission, having a reproduction number, which means basically the number of additional people who get infected by every infected person. So having a reproduction number of up to about 2.5. We think now it's probably between 2 and 3, so that holds up pretty well. And having a case fatality rate of about 4%. It may be a little lower than that. It might be closer to 1 to 2%, but even so, a very concerning picture. And when you have a highly transmissible virus with even a 1% fatality rate, that can kill a lot of people, because 1% of 1% of a few million people is that's a very large number. So we knew all that by the end of January. That was public record, and remains remains a pretty decent picture up till now. That combination of virus characteristics is like a 4-alarm fire. If you see something that has the potential to go really far, kill a non-trivial proportion of the people who get it, and be transmitted person to person, that is a real threat. And then on top of that, of course, by the end of January, we were all seeing what was happening to the health system in Wuhan, China. It was being completely overwhelmed. And I think everyone probably remembers some of the videos and pictures that were coming out during that period of hospitals being completely overwhelmed, of sometimes bodies having been left in the streets. It was very clear what was going on in Wuhan. It was very clear that in a fairly modern metropolis with a reasonably modern health system in a pretty well-resourced country, this virus was completely overwhelming them. And then, of course, China locked down their economy. And when a country that prioritizes economic growth as much as China does decides that they're going to put virus control ahead of economic growth, that is a pretty big signal. And so we knew all of that by the end of January. And that should have been enough to trigger extremely urgent preparedness measures in the United States. Instead, what we heard through the month of February was that the risk was low in the United States, and that the situation was under control, and that we were seeing very few cases. And we now know none of those things were true. The risk was not low. The risk was low only in the sense that if you see a forest fire devouring the next 3 towns next to yours, but it's not actually burning your house down yet, that the risk to you is low right now. It means you're not about to get engulfed, but it doesn't mean that the forest fire isn't coming for your town as well. And yet that's how it was heard, and that was the signal that was sent by the administration. We don't know all the reasons why they mischaracterized the risk so badly. Some of that may have been sincere, but I think what's clear in the recent reporting is that they saw the risk, they understood what was coming, and they ran into a roadblock at the top. That the president seems not to have wanted to signal to take very bold steps on preparedness, because he wanted this to be, he thought perhaps that it would go away. I don't know. But he did not want to rile the markets. He did not want to rile the public, and he was very averse to anything that would signal potential panic or concern or worry. And that really constrained the space that was available for people within his administration to more actively prepare. That began to change at the end of February and the beginning of March, when the first cases of what's called community spread, which means it is cases that are spreading locally within the community rather than coming in through travel. When those were detected in California and then Washington State, that began to shift the US government posture, and they began to then focus more on readiness within the US homeland. But by that point, it was kind of too late. The disease by that point was entrenched in quite a few different areas. It was already in New York at that point. It was already in Washington. It was already in California. It was already in Detroit. It was already in any number of different areas, but undetected because of the slow moves on testing, which everyone I think knows about. And so, we then were kind of caught in catch-up mode for March, and March was focused on trying to suddenly address all these gaps that we could have been working on for all of February. The testing gap, the personal protective equipment gap, the hospital readiness gap, all of these things that with an extra month's preparedness, we could have been much more prepared for, but also with that extra month's preparedness, we would have been able to contain the spread when it was at a much smaller and more delimited level in the country, rather than waiting until it was basically everywhere before we started to do something about it. And that takes us to where we are now. So I think where we are now, we are about a month into this phase of national social distancing and semi-lockdown, semi-shelter in place, although it's still inconsistent from state to state. And there are a number of states that have yet to implement, to put in place adequately robust measures to slow the transmission. But we are seeing in the places that have that have put those measures in place, we're seeing that transmission is slowing. That there is now a plateauing. So instead of the curve kind of going up, we're seeing the curve kind of flatten off. And from what we've seen in China, from what we've seen in South Korea, and other countries, in Italy as well, that should begin to bring cases down over the coming several weeks to a month. The social distancing will have a significant impact. We've seen already that the parts of the country that moved early on that, particularly on the West Coast and in California, especially the Bay Area and in Washington State, have not reached a level of transmission that we've seen in New York. So even that difference of, they were not dramatically faster than New York, only about a week or two on some of these measures, but that week or two's difference made a huge difference in the trajectory of the outbreak. And when you think of the difference between Seattle and New York being the difference of 1 to 2 weeks of earlier preparedness and earlier action, and then you think that we squandered the whole month of February, it really, I think, brings into perspective just how much better a position we could have been in if we had not lost the month of February. But so we are now, we're now at a point where the social distancing and shelter in place is working. It is beginning to flatten the curve and beginning to hopefully bring it down. The problem, of course, is that that's not a sustainable posture. We will not have a vaccine available at wide scale in this country for, I'll say, probably 18 to 24 months. In a best case scenario, a vaccine will be discovered somewhere around, well, a vaccine, not discovered because they're already testing candidates, but a vaccine will be found to be effective, or maybe several will be found to be effective by February to March of next year. And if that's the case, then starting from February to March, we don't suddenly have 7 billion global doses of the vaccine that drop from the sky. We need to produce them. We need to build the production network. We need to distribute them. We need to build the distribution network for those. And that all takes time as well. So, I think I am not expecting that we will have a wide distribution of vaccines before 18 months from now, and probably a best case scenario. I would love to see that be faster, but I think that's the safe bet right now. So if you figure 18 to 24 months before we can achieve enduring protection, then obviously we can't maintain the current national posture for that period. So we need to be able to shift to something else. And so then that's the question of where are we going? Hopefully where we are going is a posture of what I would call sustainable suppression, where the virus is still there, it is still transmitting, but we are suppressing the spread to a point that it is contained at a low level rather than exploding and overburdening our health system and killing people. And that is what South Korea seems to have achieved, what Singapore is maybe it seems to have achieved, although they've seen a spike recently. But that's basically our best case scenario. If we can bring cases down now and then transition to a posture of suppression. So what is a suppression posture? Suppression is basically a posture in which, instead of quarantining the whole country, which is basically what we're doing now, we have effectively everyone in the country is under quarantine. We quarantine only those people who actually need to be quarantined. We quarantine the people who, we isolate the people who have the disease, and we quarantine the people that they've been in close contact with and who are then at risk of contracting the disease themselves. And that is just classic bread and butter public health. That's what the contact tracing that Dan mentioned at the top of the call. So that enables you to target quarantine only at the people who need it, as opposed to quarantining everyone. And if we can do that, then it becomes possible to, in combination with a lot of other measures, to reopen society and reopen the economy. So, the elements of a sustainable suppression posture, there's a lot of convergence now in some of the academic and the research literature and the policy literature around this. But broadly speaking, the idea is you would have greatly enhanced disease surveillance. So we would have a COVID surveillance network across the country like we do with flu, but probably more robust, that would enable at a local level to identify what's happening with your transmission right now, and if you see a significant uptick, to identify that rapidly and adjust your measures accordingly. We do something like that with flu right now, where every week CDC collects data on flu prevalence from around the country and puts that into a chart to track what the flu is doing across the country. We need something like that for COVID too, so that if you're the mayor of Detroit, Michigan, and you see that from your surveillance data the disease seems to be ticking upwards again, then you may need to dial back some of the social distancing measures until that is brought back under control, for example. So surveillance is the first piece. The second piece is an approach to targeted quarantine instead of broad quarantine, and that rests on testing, contact tracing, and of course then supporting, leading that all into quarantine, so that when there is a case, once that case is identified, all of that person's contacts are identified and kept under monitoring for 2 weeks until they either get the disease or don't. And if they don't get the disease, then they're released from quarantine. They can go about their lives again. That's bread and butter public health. It's how most outbreaks are eventually ended. And so that is what China and South Korea and Singapore and all the countries that are doing the best on this have been doing at scale. We do that in this country, but we don't normally do it at scale. So there's a major workforce component there where we would need to hire on. There was an estimate from Johns Hopkins that proposed 100,000 contact tracers across the country who could do that work, that shoe leather public health work. Right now, we don't have that kind of a workforce, so there's a huge workforce gap before we can do that. The next piece would be protection of high-risk groups. So we've all seen what's been happening in long-term care facilities, nursing homes, prisons, detention centers. Those places will continue to be at significant risk, and they need a lot more protection and a lot more support. That's a workforce issue in part as well. It's also a PPE availability issue and a training issue. But those facilities need a lot more support to contain and prevent future outbreaks in those places. And then hospital resilience. We've seen the strain that this has put on our hospital system. There's been a lot of work to try and surge support to the New York City hospital system, to the Seattle hospital system, Detroit, some of the other places that are hard hit. But we need greater resilience everywhere. We need surge capacity everywhere, because anywhere could be the subject of a future flare-up of this disease, and we can't only invest in a few, invest resources where the current hotspots are. So collectively, that's a huge effort. And I wrote a piece with Beth Cameron and with another White House colleague of ours, Dylan George, about 2 weeks ago, that called for an Apollo program for public health. Really what we need is something on the scale and the ambition and the complexity of the Apollo program in order to get all of this done. And it will take resources. It will take a lot of workforce expansion. It will take a lot of ingenuity. It will take a lot of political will. All of it's doable, but it will take a really significant effort. And I think that gets to the last point that I want to make, which is about the big question on whether we can achieve this without federal leadership. So, we never would have thought with the Apollo program or any major American project, we never would have thought we'll just leave this all to the states and let them figure it out. The president has called this, he's compared this to a war. I think it's a useful analogy because we don't go to war as 50 different states. We go to war as the United States, and we have one national military. We don't we don't deploy to a war overseas with each state commanding its own troops and doing its own thing. We have one federal military, and I think we need a similar mentality here. We need a unified, consistent federal approach to this problem. And so far, at least, it doesn't seem like the federal government has the inclination to step up and provide that. Haley, in her comments as we opened, talked about the president saying he takes no responsibility. What he seems to want is the attention and the credit, but not the actual political risk or responsibility that comes with delivering. So he's trying to shift as much of that as he can onto the governors and onto the states. There was reporting in the Washington Post over the weekend that one of the reasons they have not produced a federal plan for this is that would give the president ownership of the issue, and he doesn't want the political risk that comes with that. I can't vouch for that myself, but it would fit the fact pattern pretty well that we're seeing. And so it's a really unprecedented thing when you think about any past major national crisis, to think that you would have a president who would not want the responsibility to end it, who would not be seizing that. It's really extraordinary. And having worked under President Obama, who of course I have a lot of respect for, when he saw these major national issues, whether that was something like Ebola or healthcare or anything else, these big, complex, politically risky national issues, he wanted to put his stamp on those. He wanted to take ownership of them, and most presidents do. It's not a Democrat thing. It's not a Republican thing. It's a president thing. The president usually wants to put. President usually wants to be at the center of any major national crisis and be seen to be fixing it, and that is what typically the American public expects of the president. So what we're seeing here is really unprecedented, but it's worrying in that to do what we need to do as a country to get out of this shelter-in-place mode that we're currently in, we do need that Apollo program level effort that really can only come from the federal government. It can't come just from the states. It can't come just from the Congress. You need the federal government to really be engaged in leading that effort, and we're so far not seeing it. So my fear then is that if we can't do that, then we're going to find that it's quite difficult to get out of the stage we're currently in, because doing so, right now we have a choice between we either nuke our hospital system or we nuke our economy. We want to get that third option. We want to get that Apollo project option where we can safely begin to reopen our economy in a way that doesn't compromise public health. But without federal leadership, it's hard to see how that's going to come together. So I think I'll stop there and turn it back over to Haley and Dan for questions.
I think you really answered the $64 question, beautifully, which I was going to ask, which is right now we are sequestering the entire country.
Yeah.
What emergency response capacity would we need to sequester only the infected people and permit everyone else to resume normal activities? So I think you have hit on that, and maybe you could just sketch out a little bit further what type of testing program in terms of scale and also type of testing would you need to have to be able to identify the so far or the existing unidentified infected cases or the cases, and then sequester them and do contact tracing? What kind of testing program would we have to have, both in terms of scope and the type of testing?
That's a great question, and that's been the subject of a lot of discussion lately. Some of you have probably seen what Paul Romer, the Nobel Prize winning economist, has put out on this, saying that he thinks we need 23 million tests a day. That would be wonderful if we could get to that point. I think there are huge operational hurdles to getting there that I'm not sure we can overcome, and certainly not in the immediate term. To kind of give a sense of perspective, right now the country is averaging up to about 150,000 tests per day. So you're talking to go from 150,000 tests a day to 23 million is just a, it's a massive, massive expansion, and there are a lot of bottlenecks to that kind of scale. I think it's conceivable to think that over the next month or two we could triple or quadruple where we are now. And even tripling where we are now would make a big difference. South Korea's testing per capita is about 3 times what ours is. So even though we are doing more tests in absolute terms, they're doing more tests relative to their population size, so they can get a better picture of how far the virus has spread and who may have it. And I think what we want to get to basically is the ability to do testing on demand for anyone who wants or needs it. So to be able to meet all the medical demand, but also to be able to meet the demand of people like one of my relatives who had a mild case of it, we suspect, but was never able to get a test. And so wasn't, he's been in presumptive, he was in presumptive quarantine for 2 weeks, but never knew for sure whether he had it or not. And that with that testing, then the question is, what do you do with the information you get from the testing? And that's where the contact tracing and the quarantine comes in. So what you want to be able to do is to have an organized system at kind of a consistent at a national level, but probably operated at a state level, that once a person tests positive, then the contact tracers swoop in, they interview the person, they get everyone that they were in touch with. So in the case of my relative, his wife, their children, everyone in his workplace, and any other close people, contacts that he had, and notify those people that they had been potentially exposed, that they were high, many of them, there would be high risk exposures to a confirmed case, and then they would be in quarantine for 2 weeks. It's possible too that if we had sufficient testing, that after a week you might be able to test all those people to see if they have some to see if they are positive or not, and if they're not, and if they can go through two rounds of tests without testing positive, that they could be released from quarantine. So even there, testing is key, because it could, in some cases, end the quarantine a bit earlier than we're doing now. And there's a tech piece to that too. There's been increasing discussion around how technology could be used to further support that. Contact tracing is traditionally something that was thought in the public health field, it was thought you'd abandon contact tracing at a certain scale, because you just wouldn't have the workforce to take that to rigorous scale. I think what we've seen from China and South Korea is that actually you can, if you put enough people on the issue, and you have big data tech innovation to support that, which they've both had, then you can take contact tracing to scale. And so I think we need to be working towards that. And then I think, so we need to build that, we need to roll it out, and then we need to see it. That's where the surveillance comes in, because once you have these things in place, then you can begin incrementally relaxing some of the measures that are currently preventing spread. But you have to do that in a really measured and judicious way, so that if something, if you see cases begin to spike up in a way that's unmanageable, or that the contact tracing can't keep up, then it's probably time to dial up the social distancing measures again. And I suspect we will have some amount of social distancing that will remain in place, really for the next 2-ish years, until we have a vaccine widely available, because it's hard to see it being safe for people to go to, large scale sporting events or other very, very large gatherings, as long as there are large numbers of susceptible people in the population and the virus remains out there.
Great.
Go into some questions that you may have received.
Yes. Okay, great. So we've gotten quite a few questions for Jeremy. Thank you for sending them in. And it's not too late. You can keep sending them to info@jewishdems.org. I'm gonna group them together by categories. So we have some that focus on how we got here. We have some that focus on our current situation, and some that are looking ahead. For how we got here, we have 2 questions. One from Noah in New Jersey. Understanding that much of the blame goes to the Trump administration, if we had all the information necessary by January, and if each state is responsible for the preparedness measures it takes, how much blame should be placed on governors for failing to take stricter measures sooner? That was Noah, New Jersey. Peter in Michigan has asked a similar question. What is your response to the Trump administration's claims that it was the Obama administration, even if it had a plan, that it failed to stock up on PPE and other supplies that were needed? And if President Obama had built up supplies as he should have, then we'd be in a much better place in 2020 and better equipped to deal with the pandemic.
Great.
Peter
So
in
I'll take the,
Michigan. Mm-hmm.
so thanks Noah, and thanks Peter. So I'll take the governor's question first. I think the governors do bear some responsibility, but I think the governors were also hampered by the fact that they don't normally have the expectation that they wouldn't be able to rely on the federal government. And so, traditionally the governors have a lot of authority to execute the measures around social distancing, but they don't necessarily have the resources or the systems to advise them on when and how they should begin doing that. And so, I think it's probably not coincidental that that Washington State was relatively better than kind of relatively earlier than this, because they had in and around Seattle, they had the University of Washington system, which has a really strong biomedical research capacity. They had the Gates Foundation, and so they had a lot of resources they could draw on locally to substitute for the guidance that they frankly were not getting from the federal government. And similar story in the Bay Area with with the tech research and biomedical research community in the Bay Area and Stanford University and so on. And so, I think that any sensible governor looking at what we were seeing in China in late January should have been wondering at that point, well, what if this reaches my state? But I think as well, they were hearing very consistently from the federal government that, look, the risk is low and the situation is under control. And so, for a governor who is not well versed in these issues, hearing that sort of and a downplaying of risk from the experts at the federal level would dissuade from taking further action. I know for a lot of the private sector that was very much the case, and a lot of the hospital sector that was very much the case. I talked to emergency room docs who I'm friends with and in contact with through the month of February, and I was saying to them, like, why on earth are we not seeing the hospitals freaking out about this? And they said, well, some of the doctors are freaking out about this, the ones who recognize the risk. The problem is hospital executives are hearing from the Department of Health and Human Services that the risk is low, so they don't feel like they need to be doing more. So I do think governors have some responsibility. I think as well, it was hard for them to go against the message they were hearing, not just from President Trump, but also from Secretary Azar and other people in HHS who would be more credible on this, hearing these messages that the risk was low. And I think that probably delayed action that might otherwise have been taken. I do think, once we were into March, then it's much harder to defend some of the governors and mayors who were slower to act. So I was stunned that Mayor de Blasio was in New York was persisting in wanting to keep the St. Patrick's Day parade open as late as he was, even once he started seeing significant spread in New York. I think that was just, he was eventually overruled on that, and his hand was forced. But his decision making on this has been, I think, a bit somewhat questionable. The governor of Florida has been terrible on this. The fact that he allowed spring break to go forward in mid-March, by which point it was really clear that we were in trouble in this country, is just an indefensible decision. But again, I think the lack of federal leadership is a factor there, because there was this interesting sort of finger pointing between him and the White House about a shelter-in-place order, where he said, well, I haven't ordered that because I talked to the White House today and they didn't tell me I should. And as soon as he said that publicly, then the White House came back to him and said, in effect, don't put the political risk on us. So then he ordered it. On the question of the Obama administration and PPE, I think I think every past administration has underinvested in health security. And that has been a persistent issue both in the U.S. and really around the world, that we underinvest in public health generally. We underinvest in health security. The Obama administration did try to put more investment into that. I think with a lot of urgency following Ebola, and ran into real difficulties with Congress on that. So if any of you closely tracked some of the back and forth over the Zika response budget. So Zika was another virus, a mosquito-borne virus that was transmitting in the United States and in the Americas in 2015 and 2016. And we were very worried about the potential spread of that in the United States. So the administration went to Congress and said, look, we need a Zika supplemental. We need money to fight this. And Congress was not supportive of that. And ultimately, most of the funding for that, if I recall correctly, I mean, I know we got a lot less than we were looking for, and I think much of it had to come from repurposing leftover Ebola funds, which were still being used for Ebola. So, Congress has not been supportive of it. The other thing I would say, so and after H1N1, the Obama administration also tried to put more into the national stockpile, and again ran into difficulty with Congress this was in the era of sequestration and so on. Congress did not have an appetite for putting money into bolstering the stockpile. The other thing I would say is the stockpile was never intended to be to exist at a scale sufficient to supply the whole country for an out of control outbreak. The idea with the stockpile was to, we didn't expect when stocking the stockpile that it would have to make up for a 6 to 8 week gap in action. And I think if cases had been detected when they began spreading in this country in early to mid-February, then the burden on hospitals and the requirements for PPE and so on would have been much lower, and what we had in the stockpile at that stage would have been much more sufficient. But certainly that's something that needs to be re-examined going into the future. I think we need to approach the stockpile, and we need to approach health security in general much more like we do other security issues. We spend, in this country, we spend about $200 to $250 billion a year on counterterrorism. And a lot of that began after 9/11, that level of spending. This needs to be something of a kind of galvanizing moment on health security, just as 9/11 was in counterterrorism, and we need to invest in it with a similar degree of seriousness. And I don't think it will be as expensive, but an extra $50 to $100 billion a year on health security would go an awfully long way.
Great. Okay, the questions keep coming, so I'm going to ask that since we have 15 more minutes, that we try to get through as many as possible here. So now we have two that are focused on the current situation. Robin from Pennsylvania is asking, who is in charge of the pandemic playbook now? And I would add to that, what is your view of the briefings, and are you concerned about the firing of Dr. Fauci? And then Richard from Michigan says, Jeremy's advocating for a federal approach. Isn't that what Trump says he wants to do?
Okay, on the briefings, I think they're really damaging. I think they undermine trust. One of the most important factors in fighting an outbreak like this is public trust. The public needs to be able to trust what they're hearing from their political leaders, because what it comes down to, how we beat this, a lot of it comes down to human behavior. It comes down to the individual choices that every individual makes. Do they follow the guidance they're getting from their government? Do they adapt their behavior in ways that curtail the spread of the disease and protect themselves and their neighbors? And to do that, they have to trust who they're hearing. They need to trust what they're hearing and trust who they're hearing it from. And this is something that we've seen in other outbreaks. For example, during the Ebola outbreak in West Africa, a lot of people in those countries did not trust their governments very much, but there were other people that they trusted, maybe their religious leaders or their traditional leaders or other leaders within their community. And so we worked with those people to serve as trusted interlocutors to pass key messages along. So you think about that in this country, the president is not trusted by a lot of the population. I mean, there are a lot of people who do trust him, but there are a lot of people who don't. And I think with the briefings, what he does is, on the one hand, I think most of the people who don't trust him or don't support him just tune out. So they're not hearing the messaging from him. The people who are hearing the messaging from him are hearing things that are inconsistent and very often wrong, or at least misleading. So we were hearing through much of February that this would not be much worse than the flu. Obviously, that flu does not overwhelm hospitals the way that we've seen in New York. So that has been proved incorrect. The comments he makes about hydroxychloroquine as a treatment, also misleading. It may or may not prove effective. So far, the testing, the research that's been done suggests it isn't very effective, and it carries very high risks with it. So he is providing a lot of misinformation in those briefings, and sometimes verging into disinformation in those briefings. And so I think the briefings are pretty are actually harmful. In terms of who's in charge of the playbook now and the role of Dr. Fauci, the way that you said it, Haley, it sounded like he had been fired, which I don't believe he has been.
No, I said, are you concerned he might be? Sorry.
Okay, yeah, I just wanted to be clear on that, because you said the firing to Dr. Fauci, and I thought, oh crap, did I miss something?
Nope.
No, I think that the role of Dr. Fauci is extraordinarily important. He is, as everyone on this call knows, he is a brilliant doctor, a brilliant health communicator, and one of the few people who seems to be able to speak truth to power about the current outbreak. And I think it would be, if he were to be fired, that would be a red flag moment that would stand out even in the sea of red flag moments that we've had on this pandemic. I think it would be very politically difficult for the president to fire him, and I think Dr. Fauci probably knows that, and I think he's probably pushing the envelope as much as he feels he safely can, and I'm grateful to him for doing that. In terms of who runs the playbook now, well, no one. The team at the White House that had been established to manage that was dismantled when John Bolton came in and folded into some other parts of the NSC, mostly into the directorate that deals with weapons of mass destruction. And I think I criticized that at the time. A lot of other commentators and researchers criticized that at the time, because managing a pandemic is very, very different than managing a nuclear, chemical, or biological attack. It's just a very, very different sort of event, and conflating the two together, as John Bolton's reorganization did, basically ensured that the pandemic stuff got less attention than the weapons of mass destruction stuff, because that was the risk that he cared more about. The other big change that they did around the same time was shifting the overall leadership for an event like this out of the White House, where it had been put by the Obama administration, shifting it over to the Department of Health and Human Services. And likewise, many of us at the time thought that was a mistake, because this is a whole of society and the whole of government effort, and you have to have a leadership structure that reflects that. And so that means it has to be in the White House. It can't just be in one of the agencies that needs to be involved. And I think, in a sort of a backhanded way, that's where the Trump administration ended up as well, because when things got really serious, what did they do? They took the leadership out of HHS and they shifted it back into the White House. They gave it to the vice president, and they put a team around the vice president based out of the White House. So, they've ended up back in the same place, but only after doing a lot of after a lot of bumbling in the interim, which has left us in a worse position.
Okay, we've had a few questions on the state versus federal issue, which obviously came up yesterday in the briefing. So Oliver from DC is asking, what can municipal officials be doing now to help prepare the infrastructure for vaccination and antibody testing? So I would add also, we're talking about local governments. Michael asked, did your playbook address the issue of the federal versus state government in the case of a pandemic, and what were your recommendations there? Why do you suppose state governments haven't formed a consortium to acquire and distribute PPE ventilators among themselves rather than bid against each other, which has driven up the price? Yeah. And Steve from Atlanta asked a similar question. Assuming the Trump administration continues to slow the federal allocation of PPE, shouldn't states enter into compacts to approximate what the feds should be doing?
Yeah, I'll start with the last bits first, because that's actually starting to happen now. We're seeing that with some of the states in the Northeast. We're seeing that with some of the states on the West Coast. that those kind of, oops, sorry, that those kind of, sorry, that was my cell phone, that those kind of compacts are starting to happen, and they're happening for exactly the reason that the questioner has just outlined, which is that it doesn't make sense for these states to all be competing against each other. We may find ourselves in this weird sort of a place where we have regional compacts of states competing against each other instead of individual states, and that raises the question of, gee, wouldn't it make a lot more sense if all of those states were to federate into some sort of united body that could do these things jointly for all of them rather than just for subsets of them, and maybe we could have a constitution and bylaws and things like that. But yeah, we are seeing that, and we're seeing that be as a direct reaction to the failure of the federal government. The federal government on things like PPE procurement, ventilator procurement, sent very conflicting signals to the states. It said, on the one hand, the president said pretty explicitly, you're on your own. This is your responsibility. You guys go take care of it. Jared Kushner said the stockpile is ours, not for the states, and changed the website when it contradicted him. For the stockpile website had contradicted him, and that got changed within hours of him saying that. But what that did for the states is it put them in a position where they were competing against each other, but they were also competing against the federal government, because the federal government was still trying to buy PPE and still trying to buy ventilators. And there were multiple reports of states who would be very close to finalizing a purchase for something, only to find they lost out on the bid to the federal government. So the federal government was both saying to the states, you're on your own, go buy your own stuff, but still buying as if it were itself responsible for covering those needs. And it just created an insane situation in the marketplace, and I think underscores why there are certain of these functions that just really have to be owned at a federal level. They can't be left solely to the state. And it's not efficient, and it leads to these very messy situations, and it's much better to have some of these things centralized at a federal level and then have the federal government support the states rather than, in effect, kind of putting itself on par with them and competing with them. The federations of states that are now emerging to counteract some of that, I think, are it's better than having each state individually compete, but it's still not as good as having a coherent federal system. I think what you would ideally want to have for PPE is you have hospitals continuing to do their normal purchasing as they would, and to the extent that they can. And then for the extraordinary purchasing, you have that centralized through the federal government. And then the federal government provides equipment and supplies to the states on a transparent and objective basis based on need. Because we don't need to be surging ventilators and PPE everywhere at the same time. But when there's uncertainty about whether the federal government will come through for you, if you're a state, well, then you need to be buying as though you're in surge mode right now, because you would need to be building up your reserve. So rather than kind of trying to build up one reserve at a federal level, we've created a situation where each state, whether or not they are actually seeing a surge in cases right now, has to build up a surge reserve right now to be ready for what's coming. It would be much more efficient and frankly much less of a strain on the market if we just needed one reserve that we could roll to different parts of the country depending on where we're seeing a surge in cases at any given point in time. And then you don't need everyone simultaneously trying to build up their own kind of extra reserve of supplies. The logistics here are just insane. And again, that's not like a particularly difficult insight to understand. And yet the federal government is getting it wrong.
Okay, we're gonna go into a bit of a lightning round now. You've done a very good job. We've never actually had this many questions on any call, so I think that's a testament to how great this briefing has been, Jeremy. So thank you. We're gonna keep it going. These questions I would categorize as looking ahead. Penny from Maryland is asking, what about the antibodies testing? Ike from Virginia, related. If we know that an exposed person cannot get sick again, then is it not imperative that everybody have an antibody test before we open up our economy and society? Like what happened with SARS? Josh from DC, what will American economic and social life look like between the time restrictions are loosened and the time at which a vaccine is available? And he's also asking, what sorts of measures do you expect employers will have to take during the partial quarantine phase in order to operate? Finally, Ariana from Pennsylvania, related. Should a 65-year-old plus person who knows he or she is in another high risk category remain sheltered at home until a vaccine is available for that person?
So I'll take the testing first, and I realized I didn't address the earlier testing question. So I think antibody testing is going to have a really important role to play. I would stress, though, there's a lot we still don't know about how this disease will work. We don't know how much immunity it will confer upon people who've had it. Normally with a virus, once you've had it, you remain immune for at least some period before you can get it again. There is some research that has come out that suggests that the the residual antibodies may be lesser here than we're used to seeing with other viruses, and what that will mean for the duration of the immunity or the strength of the immunity that it will confer is a big question mark. We just don't know yet. Hopefully we'll see it behave like other viruses do and leave immunity for at least a couple of years, but that still needs to be studied, so we can't assume that will definitely be the case. Antibody testing is very useful in the immediate term for getting a sense of how many, how far has it spread, and if we knew, for example, that if we know that 5% of the population has had it, that means we've got a lot of susceptible people still out there. If we thought that 50% of the population had had it, then that's a very different risk picture. So antibody testing is quite important for that reason. In terms of getting a general population view of how far the virus has spread, it can also be useful in certain fields. So if you're a frontline emergency responder or health worker and you've survived and you have a degree of immunity, assuming we find that it leaves that, that's a very useful thing to know, because then then you can go back to your job without having to worry that you're susceptible or that you could be spreading it to others. So far the antibody testing has not been able to go to scale. There is some progress on that, and I think that over the coming months we'll see that reach a larger scale. Whether that will be something that will be available to every employer, I don't know, and I don't think we need every employer to do that necessarily, but in certain, we'd probably want to prioritize it first for certain fields and certain careers where people are either at particular high risk or pose higher risk to others. So, people in nursing homes and things like that. On the question of what life will look like and what employers need to do, I think life is clearly going to be different. I think until we have a vaccine, I think large gatherings are going to be almost impossible. We'll see, and it depends on what we know about the level of residual immunity that may already exist in a community. But it's hard for me to see it being safe or advisable to put 500 people, much less 50,000 people, in an indoor enclosed space in the next 2 years. Now, I hope I'm wrong on that. I would like to be wrong on that, but right now it's hard to foresee that. As long as we know the virus is out there, and as long as we know that there are a lot of susceptible people in our community, those sort of gatherings are a pretty significant risk. I think smaller gatherings could be more feasible, and then I think that's a matter of kind of risk tolerance and risk calculus. If we think that, for example, our disease surveillance gives us a pretty good picture that we are not seeing a high level of spread in a given area, and the contact tracing is robust enough that most of the new cases we're seeing are coming from among identified contacts, then you can be somewhat confident that it is being controlled, and then you can be a little riskier in terms of gatherings. But frankly, it's going to be experimental on that. We're going to need to experiment, see what happens, adjust accordingly, experiment and adjust. And I think we're going to see this kind of cycles of experimentation and adjustment in the strictness of the measures over the coming 6 to 12 months as the world figures out how best to protect itself against this. On the question about 65 and over people with comorbidities or other health problems, again, I think for now, yeah, definitely. My parents are in their 70s. They have health issues. I have strictly told them not to leave the house, apart from the occasional walks at great distance from other people. Will we get to a point where that's no longer necessary? I think it's like the gatherings thing. If you're confident that in a community there is not a high level of active transmission ongoing, and that the transmission that is there is being well monitored, then I think the risk is lower. If we, I think we'll probably move to a place as well where anytime anyone is indoors, they wear a mask for the next 2 years. The risk is lower outdoors, but indoors, what we've seen with a lot of the transmission is that indoor proximity in an enclosed space over a sustained period is a particular high risk exposure, and so that will probably masks and help somewhat to mitigate that, but not fully, but they help mitigate somewhat. So I think we're gonna learn more about how we need to adjust, and people will adjust. People are adaptable. We're going to have to get used to a lot of things that are pretty unfamiliar, but I think we will find ways as a society to make it work.
Great. Thank you so much, Jeremy. As you mentioned, we met almost a decade ago. You were trying to save lives in Somalia. Who would have thought we'd face a crisis like this here today? But yeah. You're still trying to save lives, and we appreciate it so much. I'm going to turn it over to our chairman of the board, Ron Klein, to wrap up our call today. And I'll just say thank you to everyone who sent questions. I'm sorry we couldn't get to them all, but there will be another call next week. And thank you so much to Jeremy.
Thanks, Haley. And thank you to Dan for the introduction. And Jeremy, thank you very much for your time. This is a moment in which people are yearning and really want good information, good quality information, so that they can get through the uncertainty and the imbalance and the way they're living their lives right now. So hearing it straight from you who had the experience, and this is just talking very soberly about the opportunities and challenges. That's exactly what Americans want to know. We are a resilient people, and just give us the information, talk straight to us, and we'll all get through this together with some disruption, but we will get through it. I would like to thank everyone for joining us on our 6th call. This is the series we call Democrats Leading in Crisis, and we thank all of our speakers who have been sharing their thoughts, their time, and their insight with us. We're picking a different subject each week relating to how people are dealing with the impact of the virus and what our government's approach is. Our next call will be next Tuesday, April 21st at 4:30 p.m. Eastern Time with Congresswoman Haley Stevens from Michigan. She's from Michigan's 11th District. Congresswoman Stevens will address the situation in Michigan specifically, as well as her experience in speaking with members of Congress from other communities around the country that are hotspots and dealing with some of the logistics and some of the healthcare crisis issues in their communities. She'll also speak about the 4th stimulus bill that is winding its way slowly through Congress to try to deal with some of the continued issues on funding of small businesses and dealing with the healthcare crisis in our hospitals and the protective care necessary. Please also visit our website, jewishdem's.org, to support us, JDCA, and learn more about what we're doing. Join one of our state chapters. Those of you who are listening who are in college, we have chapters in colleges when you return, hopefully in the fall. You can also sign up for JDCA's first National Day of Action on May 17th. We're organizing digitally in advance of the most important election of our lifetime, and hope you will join us by supporting JDCA. So we hope to see you again next week. Chag Sameach, and stay healthy and safe. Thank you and have a good afternoon.